Welcome to Physician Focus. I'm Dr. Bruce Carlin. In 1981, the United States Centers for Disease Control and Prevention described a rare, then unidentified lung disease affecting the body's immune system. It was the first official reporting of what would come to be known as human immunodeficiency virus, or HIV, the virus that leads to AIDS. 30 years after its discovery, HIV and AIDS are still major public health concerns. Today, more than 1.1 million people in the United States are living with HIV, and of those, about 16% do not know they are infected. Some 50,000 new infections occur each year, and 15,000 people die each year from AIDS. Worldwide, 34 million people are living with HIV, with about 2.5 million new cases each year. Nearly 30 million people with AIDS have died since the epidemic began. This edition of Physician Focus will examine the impact of HIV and AIDS have had over 30 years since their discovery. We'll look at such areas as the impact on personal and public health, who is most at risk, how the disease is treated, public health strategies to reduce its incidence, and what may lie ahead for possible vaccines or cures. With me for this discussion is Dr. Thomas Treadwell. Dr. Treadwell is board certified in internal medicine with a subspecialty in infectious disease and has been active in the treatment of HIV and AIDS since the diseases first appeared in the United States. He is currently the director of the Infectious Disease Clinic at Metro West Medical Center in Framingham, Massachusetts. He is also an assistant dean for academic affairs at Boston University School of Medicine. Welcome, Tom.
Thanks for having me.
It's nice to have you here. You've been there right from the start. I understand that you started your fellowship on July 1st, and what happened 2 days later?
Well, so I arrived in Boston, working at the Maxwell Finland Lab for Infectious Disease, and right the first week we were there, this report came out, and if you're in the area of infectious disease, one of the things you look forward to every week is this report.
Morbidity and Mortality Weekly Report.
From the Center for Disease Control. And this may be the most famous report in their history. And it was a stunning report that no one understood. But it reported an outbreak of deaths in previously healthy gay men who were developing strange tumors, Kaposi sarcoma, and a very unusual lung infection called pneumocystis pneumonia. And this epidemic was first reported then. It had been brewing for a couple of years in retrospect, but this was the first report. And at the time, what people were seeing in abundance, actually, were previously healthy young men who were developing pneumonia, and that's a chest X-ray of somebody with pneumocystis pneumonia. And pneumonia in itself isn't that rare, but what was very unusual is that pneumonia was caused by a fungus called pneumocystis, or pneumocystis carinii, and that's a lung biopsy on the left showing that. And what was stunning about this outbreak is that healthy people never get pneumocystis pneumonia, and it meant that whatever was causing this epidemic had resulted in a severe derangement of the immune system. So that was the first description. And for the next several years, in Boston and throughout this country at least, there were just more and more cases of mostly gay men, but also persons who used intravenous drugs.
But, and these pneumonias were
right.
fulminant.
They were generally fulminant pneumonias.
They just came on in a huge flurry and killed people quickly.
They did. Some patients had a more smoldering course. And once it was recognized what this was, because it wasn't initially apparent, there is treatment for this. But these people tended to have really destroyed immune systems. And pretty much most of the patients early in the epidemic died within weeks or months of the diagnosis. And the first few years were particularly dark because there was a lot of fear. There was a lot of uncertainty about what was causing this. The virus that causes HIV, or the virus HIV, wasn't known then. And in fact, it wasn't until 1984, 1985 when researchers in Paris and in Washington deduced that this was an RNA virus, a so-called retrovirus, now called HIV, then called HTLV3. And at that point, there was a big turnaround because there was a blood test. So by March 1985, we could actually test people for HIV.
But I remember early on where we didn't know how it was transmitted.
Right.
You didn't know.
Yeah.
You take all these precautions, and really we should have been taking precautions because we were more dangerous to the patients than the patients were to us.
Right.
But there was this big unknown at the time.
It was, and you know, it was a really truly horrible time. Certainly for the patients, but also because there was so much uncertainty. Didn't even know what was causing it. And even after we had a blood test, there was no treatment, and people were still dying of these unusual infections from having a destroyed immune system and wasting illness. In the next decade, 1985 to the early 1990s, there were more and more cases. There was treatment. A drug called AZT was first introduced in 1986, and although it had a lot of hope for patients and had some minor benefits, still the number of cases still increased, the number of deaths increased, and it really was a hard time. And then in the 1990s, scientists were able to really get a handle on what HIV really was. They were able to figure out the dynamics of the infection, and more importantly, they were able to figure out that if you're going to treat this infection, you need powerful drugs, and that's when the so-called protease inhibitors were introduced, and you're going to need to use more than one drug, and that was the so-called HIV cocktail, or highly active antiretroviral therapy. In 1994 and 1995, this concept was introduced using triple therapy to treat HIV. And for the first time, and you can see in this graph, for the first time, the death rate from HIV started to fall. These infections like pneumocystis started to disappear. The infections started to disappear. The number of deaths started to fall. And you can see in the yellow line that as the number of patients in this country who were on treatment, on cocktails increased, the death rate for the first time fell. And this was really a bright time. Now, in the next decade, there's still been tremendous advances. There's now more than 20 drugs to treat HIV. There are better testing across the country. And then more importantly, there's been worldwide efforts to treat HIV as well.
So we've migrated from this nebulous area where we didn't know what we were treating, and we just watched, sort of wrung our hands as we watched patients die, to a point where we can really manage the disease.
We really can.
How are we doing?
Well, we're doing much, much better because the early sort of cocktail era, as fabulous as that was, it was difficult. There were lots of side effects of the meds. Patients were taking 16 and 20 pills a day. The medications themselves caused some disfigurement. And so I would say the next decade or decade and a half led to, first of all, better mousetraps, better drugs, simpler regimens. And now most patients with HIV infection are treated with one pill once a day. I mean, it's really incredible, the advances that have been made. So there have been really tremendous advances, less side effects, more simple regimens, and most importantly, more and more people being treated, not only in this country, but even worldwide, even in really developed countries where HIV is really hit hard.
So where do we stand now? We've got perhaps not as accurate as we'd like, but old pictures of the epidemiology of this.
In this country, there's about 1 million cases of HIV, just over 1 million cases, and of that, about 15% don't know the diagnosis. And most people in this country are on therapy or are candidates for therapy. Worldwide, of course, the epidemic is has affected more than 30 million people with lots of deaths still due to infection. The heart of the epidemic is in sub-Saharan Africa, particularly southern Africa, which is in red here. But this is a worldwide epidemic. This is a graph that has really self-reporting, so the cases in Southern Asia, Southeast Asia, perhaps aren't definitely
as well represented
as
they might be.
But for example, India, a country where 10 years ago the health ministers said that HIV is not a big problem, India as a country probably has more cases than any other country in the world. So this is a worldwide epidemic. In the United States, the incidence of the infection is about 1 in 1,000. Across the population, but there are parts of the country and there are parts of the world where, in certain localities, the infection may reach 5% or higher of the population, which is a real disaster.
So how are we doing in the U.S. here?
Well, the United States, this first of all not an equal opportunity infection. It's affected patients of color much more than patients not of color. So in the United States, approximately 12% of patients are black, but about 50% of patients and 50% of new cases are in African Americans. And Latin America, Latinos are also represented more than in the general population. And in the Commonwealth, about 30,000 patients have been afflicted with HIV, and it's in the Commonwealth of Massachusetts. The demographics are about a third. A third are among gay men, a third of heterosexually transmitted cases, and about a third contracted HIV through needle use. And one of the statistics, though the death rate has fallen, one of the, I think, statistics that still is important is there's still 50,000 new cases a year in the United States. So it's although the death rate is better and the outlook is better, we're still seeing more and more cases of HIV, not only in this country, but worldwide.
But that's in your wheelhouse. As an infectious disease epidemiologist, you're always doing, following cases and trying to decrease the exposure that might be out there. What are we doing? What should we be doing? How should we be testing?
Sure. Well, so as you know, we've had a test since the spring of 1985, which was a huge development because, first of all, you could test patients, and equally important, you could protect the blood pool. So transfusion-related cases, which were a huge problem in the mid-'80s, have now disappeared, fortunately. But testing, I think we've been very slow to adopt sort of universal testing, and I think it's because the stigma of HIV, from the early epidemic has still lingered to a lesser extent, fortunately. But I think one of the most important things about bringing the number of new cases down is to test those 15% of patients, to get them tested. And the U.S. Public Health Service now has a policy of recommending testing for all young people. Young people is defined as age 13 to 65. I love it when people say a 60-year-old's young, but everybody in that age group should have a single HIV test, and more often if they're in a risk group. So I think getting people tested, certainly we've been testing all pregnant patients for some time, and that's had a huge impact on neonatal transmission, which almost doesn't occur, at least in Massachusetts.
You can protect the fetus,
you can,
even in
by
an
treating the
infected
mom. That's right. But of course, you need to know the mom's infected, and again, I think that if you know somebody's infected, then you can treat them, reduce the risk of horizontal transmission, and get them into therapy.
Horizontal transmission?
So horizontal transmission means sexual transmission or transmission from needle sharing, for example. So I think that's very, very important.
So how are we doing in the Commonwealth in terms of our testing? Are we stepping up to the plate?
I think I don't have the statistics. The Commonwealth was one of the last states, shame on us, to adopt so-called opt-out testing. And until last year, in the Commonwealth, you still need written informed consent to do an HIV test, which the CDC recommended against. But we're over that. And you still have to ask permission, but you don't need to go through a rigmarole. And I think, now that HIV isn't a death sentence, now that it's very, very treatable, and now that diagnosing new cases has both implications for the patient and for the public health, I think it's important that we spread the testing net wider and wider. I think it's really crucial. You can't treat a patient if you don't know they're infected.
One of the things that, one of the positive turns that I've seen is a lot of my patients are coming to me. I've just started a relationship with so-and-so,
Sure.
and they insist that I be tested.
Sure.
And so I'll test for
Sure.
the usual sexually transmitted diseases, but they're all asking now for
Sure.
HIV and Hep C and
Absolutely.
other testing. So it's a positive turn. And maybe it's something that we should put as a positive.
Yeah, it is a positive, and I think we, as a training director, one of the things we teach our trainees is that that all of your patients, and I think there's a stigma attached still to testing, and so one of the lines I use is I ask all of my patients to get HIV testing. So when you ask somebody, they don't think that, what does he think I am? So I think that,
you get
testing,
by the...
Yeah, I think people used to, and maybe still do, they used to hate to go to the laboratory with that to get blood drawn for that. But now that they know everybody's getting tested.
So what do? They go to the lab and they say, oh, you must be one of Dr. Treadwell's patients, right?
Yeah, but not, I'm not the only person testing. So,
right,
and I
that's
think
good.
That's been an important development.
So how are we treating it now? How do you get somebody down to one drug after it was
Well,
so
it's not
hard?
one drug, it's one pill. So we're still using combinations of pills, typically 3 antiviral medications at once. But the industry, the pharmaceutical industry, has gotten better and better at getting smaller and smaller pills, better combinations, less side effects, and more durable responses. And if you can get patients to take their pills on a regular basis and not miss them, I think that the outlook for patients, the life expectancy for a newly diagnosed patient is nearly normal. And this is a tremendous, I think, in terms of getting people tested, particularly people in risk groups. When you can tell them that, look, if you have HIV, we'll be able to treat you and you'll have a normal and near normal life. I think that's a huge, huge benefit.
So what do you tell the patients? You say you will have a near normal life?
Well,
What things do you tell them?
I think that, I tell people that there are a lot of diagnoses now that are worse than HIV. And I tell them that the bad news that HIV is not curable, but neither is diabetes, neither is high blood pressure. And like patients with diabetes and like people with high blood pressure, you're going to be on medications the rest of your life. And you need to understand that and to accept that. But now that we have simpler regimens, simpler medication combinations, again, often one pill once a day, that have very limited side effects, usually no detectable side effects. I think patients are taking their medications, their immune systems are returning to normal. You can't measure the virus in their blood typically. They're not cured, so people need to understand if they stop their medication, the virus comes back. And we've also now recognized that HIV, beside the potential to cause AIDS, also has some other deleterious side effects. It increases the risk of heart disease, it increases the risk of kidney disease, increases the risk of stroke. And so we're treating everybody now in this country. We're not just treating patients who have low immune systems or low lymphocyte counts. The really concept now is to treat everybody who's diagnosed. So
the measure of how much the HIV virus is affecting you is the lymphocyte counts and the blood counts.
Right, and that was a huge development in 1990. The ability to actually measure the virus in blood commercially, and that's really one of the things that really turned things around.
So now, even if you've got pretty good blood counts and pretty good measures by the old criteria, we're saying we treat you because of the other effects of the HIV virus.
That's correct.
And the drugs suppress it.
That's correct. It also is true that there's a public health benefit to treating infected individuals too. And although we always counsel our infected patients with HIV, that they have a responsibility not to infect those around them sexually or with drugs. It's when patients are undetectable, when they're on therapy, the risk of sexual transmission is very, very low. It may be not zero, but it's very, very low. So there's not only a personal benefit, but a public health benefit.
So now, what do you tell your patients in terms of things like sex and what they should and shouldn't do, and what other things are they allowed to do or not allowed to do?
Yeah, I mean, I think
that's a relative term.
It's a relative term, yeah. And we counsel our infected patients that it's their responsibility to tell sexual partners that they have HIV, that they should wear protection, even if they're on antiretroviral therapy, because there is. Nobody can say that if you're undetectable, the transmission rate is zero. But it's better than if you're not on therapy. And so we still counsel people to act responsibly, to use safe sex, to notify their partners. I think it's important to also have that message as well.
Are there special subpopulations that you treat differently, like your addicts and drug abusers?
I don't. I take care of sort of equal numbers of the three major risk groups, and I don't see huge differences. I think one of the things we're seeing is that new cases of HIV are seldom people who inject drugs. And I think that people who do inject drugs have gotten the message a long time ago that sharing needles is not a great idea. So we're seeing fewer and fewer patients infected, at least in the Commonwealth, through dirty needles, and that's been a benefit.
I was just thinking in terms of responsibility of patient responsibility. Even the IV drug abusers are taking responsibility these days.
Yeah, I think so.
That's pretty nice.
I think it is nice, and I think obviously using intravenous drugs has never been a good idea, but certainly if people are going to use intravenous drugs, we want them to use clean needles, their own needles, and not share them. I think that's crucial. I think needle exchange programs have been very successful in preventing not only HIV but hepatitis C, which is a new epidemic. So
moving forward, we've got a few more minutes, but only a few more minutes. What's the future for HIV? Where are we headed? What's the research? Are we going to have a vaccine?
Yeah. Well, clearly, I think the most exciting thing is the introduction of antiviral therapy in developing countries. So clearly, let's not forget about the 30 million people in sub-Saharan Africa, in Asia, Southern Asia, and in other parts of the world. So I think that's, and there's been tremendous improvements in coverage for antiretroviral therapy, antiviral therapy in developing countries.
The cost has come down. That was a big breakthrough.
The cost has not come down in this country yet. I think it's going to, but certainly worldwide, the cost has come down through patent sharing and ignoring patterns, and so the cost of therapy is
so that we can treat some of these 30 million. Yeah.
And I think that's important. Vaccines, of course, there's a lot of research for vaccines. You have to be a little pessimistic about vaccine for this very tricky virus, but research is still going on. And there's a tremendous amount of research going on about the potential for HIV cure as well. That's not an area of my expertise. There have been some success stories, but there's been some disappointments recently that you've probably heard about in the news. And I think a cure is a long way away. I think it's some exciting research, but I think I tell my patients not to count on that and to get used to taking their medications for life. I think you need to.
The analogy with diabetes is certainly apt, because we thought insulin was a cure, and of course it isn't. You've got to treat there are other things that you need to do to treat the disease, and I think it's probably very similar with HIV.
Sure. I don't mean to imply that having diabetes and having HIV are similar. They're not. But I think the concept of of not curable, but great treatment and improvement in life expectancy are true for both sets of diseases.
Would you have any recommendations for the average person going out and living their lives these days, vis-a-vis the things that, or behaviors and protection that they should do going forward?
Well, I think it's very important to note that one of the downsides of these great improvements in the treatment of HIV has been that that communities of young people have stopped worrying about dying of AIDS and have started becoming less careful about safe sex, for example. And we now have an epidemic of syphilis. We now are seeing increased rates of gonorrhea. Those infections disappeared when young gay men, for example, started seeing their friends dying of HIV. And now that people aren't dying of HIV and HIV is treatable, we're seeing, a resurgence in STDs. And so I think that young people need to be aware that it's not only HIV. I always say that sexually transmitted diseases are like bananas. They come in bunches. And there's a lot of sexually transmitted illness still out there, even in the suburbs. And people need to be careful. And
well, this has been a wonderful tour of HIV with Dr. Tom Treadwell, and thank you for being our guest. For more information about HIV/AIDS, visit the websites listed at the end of our show. And to view past Physician Focus programs, visit our website at physicianfocus.org. I'm Dr. Bruce Carlin. Thank you for watching.
I'm Dr. Tom Treadwell. 30 years ago, the Centers for Disease Control described a rare, unidentified disease affecting the body's immune system. It was the first reporting of what would later be called AIDS. Today, HIV and AIDS remain leading causes of death and illness in the United States. More than 1.1 million people now live with HIV, and more than 15,000 die from AIDS each year. Those most at risk are gay and bisexual men and injection drug users. But heterosexuals are also at risk. And every year, 50,000 new infections occur, and many don't know they're infected. Health officials recommend routine screening for all patients after notification in an effort to foster early detection, and annual testing is recommended for all patients at high risk. Talk with your primary care provider about the importance of HIV screening. The conversation could save a life. For more information, visit AIDS.gov.
I'm Dr. Albert Tremaldi.
I'm Dr. Maggie Ham.
Hepatitis is a disease of the liver, a major cause of cirrhosis and liver cancer, a leading cause of death by infection, claiming some 15,000 lives each year.
Hepatitis is actually a group of 5 unrelated viruses, with one of the most common being hepatitis C. Most patients who contract hepatitis C develop a chronic or long-term infection.
More than 4 million Americans are living with chronic hepatitis, yet most do not know they are infected, putting them at risk for complications and increasing the likelihood of spread of the disease to others.
Some of the highest rates of hepatitis C appear in those born between 1945 to 1965, the so-called baby boom generation, and health officials are urging those people to get tested for the disease.
If you're in this group, call your primary care physician to arrange for testing. The good news is that hepatitis C can be successfully treated with medication.
For more information, visit the U.S. Centers for Disease Control website.